conduction system of the heart. Your main goal on this page of your notes is to really understand how the electrical signal passes through the heart in such a way that the atria end up contracting first and the ventricles after. Okay, so let's start off in the right atrium with a frontal section of a heart for you here. There are a group of cells in a portion of the right atrium that are called the sinoatrial node. And that's where the signal begins. Sometimes this is called the pacemaker of the heart. And these cells are autorhythmic. What that means is that they can generate an action potential without nervous input. And left to their own devices, they'll generate about 75 beats per minute. Now these cells then spread out around them, or they send their action potentials all around the right atrium. And they pass through the wall between the right and the left atrium and cause action potential to be propagated all the way through the right and left atrium. And what that means then is all of the atria are depolarized, followed quickly by a mechanical contraction. So the atria contract first, and they squeeze their blood down into the ventricles. But that is not the only autorhythmic group of cells. There's another autorhythmic group of cells in the right atrium called the AV node, or the atrioventricular node. And it gets its name because it's at the bottom of the atria and at the start of the ventricles. And these cells are also autorhythmic, but they are autorhythmic at a slower rate than 75 beats a minute, so they usually just obey the SA node. So you can see it's a backup measure. If something were to happen to the SA node, the AV node could keep the heart beating. And so, of course, then the signal comes from the SA node to the AV node. Now, the AV node passes its electrical signal to the middle muscle of the heart. And there's another group of autorhythmic cells called the AV bundle at the top of the interventricular septum. In the old days, we called this the bundle of His, named after the scientist that discovered this particular part of the pathway. So the signal goes from the SA node to the AV node to the AV bundle. Now, like I said, the AV bundle is also autorhythmic, meaning it can generate its own action potentials even if no one tells it to. You can see that it's slower than the SA node. If the AV node is damaged, we call that heart block. And what happens then is the signal can't get from the SA node to the AV node and then to the AV bundle, but the AV bundle keeps generating its own action potentials, so you still will have the ventricles contracting at a very slow rate of 40 to 60 beats per minute. So in a heart block, if damaged, and it prevents the signal from reaching the ventricles. Okay, then the bundled branches has the electrical signal goes down the sides of the interventricular septum to depolarize the right and the left ventricles. So this would be number 4, bundle branches. And then number 5, purple, the Purkinje, named after a famous anatomist. Purkinje fibers, they send the signal up the sides of the right and left ventricles. So the last area to depolarize and contract is going to be the top of the ventricles. So you get the contraction first occurs through the atria and squeezes blood down into the ventricles. And then the contraction starts at the bottom of the ventricles and squeezes the blood up and out of the pulmonary trunk and the aorta to go to the systemic and pulmonary circulation. So again, the take-home is that ultimately the atria contract first, and then that's followed by the ventricles, which contract from the bottom up. Oops, sorry you couldn't see all of that. So you can modify the beat. This is 75 beats a minute. If all of these nodes are working as they should, then the heart would beat just at 75 beats a minute. If the AV node is blocked, then the ventricles would contract at 40 to 60 beats a minute, if there was a heart attack, for example. But in the case of a healthy heart, you can modify the SA node with nervous input. So we're going to use a green pen or highlighter to represent parasympathetic input on the heart, and this would be coming from a branch of the 10th cranial nerve. Hopefully you remember that that would be a branch of the vagus. That's cranial nerve number 10. And this would be the parasympathetic input on the heart. That's why we did it in green. And hopefully you'll also remember what neurotransmitter would be released onto the myocardial cells right there. And that's acetylcholine. And hopefully we'll also remember that it will be released and bind to cholinergic receptors And then the ultimate effect of that, again, a review from Biology 241, is that by binding to the cholinergic receptors, then potassium is allowed to leave the cell, and the hyperpolarization hyperpolarizes the myocardial cells. And if they are hyperpolarized or more negative than usual, then they are going to be less likely to fire action potentials. And it will decrease heart rate. But not only that, it also decreases the strength or the force of the contraction, or what we call contractility. Now, you probably remember that sympathetic is going to have opposite effects. So let's use a pink highlighter to represent that kind of modulation. And this is more likely to be coming from a branch off of the spinal cord, right? So this would be a sympathetic neuron. And that would be coming from the spinal cord. Do you remember the cranial or the thoracolumbar branch of the peripheral nervous system, or the autonomic nervous system, is between T1 and L2, right? So you have a neuron there that then will synapse in the sympathetic chain ganglia and then send a fiber to the SA node. And it will release not acetylcholine, but norepinephrine, which will bind to specifically a type of adrenergic receptor. Do you remember? Beta 1 adrenergic receptors on the myocardial cells. And what that will do is allow more calcium to be available, both at the axon terminal for the releasing of norepinephrine, but also allowing more calcium into the myocardial cell. So it increases calcium availability in the cell. And you remember calcium is required for muscle contraction. And so this will increase both the rate at which the heart beats by its effects on the axon terminal and the depolarization of the cell. And it will also increase contractility, or the force of contraction, merely by having more calcium available for the myosin heads in muscle contraction. Okay, now let's go down to the bottom of this page. We're going to look at an EKG. So in this EKG, that stands for electrocardiogram, or ECG. And what that literally means is the electrical writing of the heart. Like if you get a telegram, it's a writing from far away. Tele means far. So this is the electrical heart writing. And it used to be called an EKG, is also a common way of seeing that, because German spelling of cardio is like that, cardio, and the Germans were instrumental in developing this procedure. So on the x-axis is time, and on the y-axis is voltage. And this is looking at the whole heart. So if they put electrodes, let's say, kind of at this angle across your chest, then they're going to be able to read the electrical signal heading through the heart at that angle. And then each of the traditional bumps that are seen is given a name. So the first bump is called the P wave. And what is represented there is the depolarization of the atria. So this first part right here, as they depolarize. And then look at this really big electrical activity you see. When you're looking at EKG, don't worry so much about it going down. It's the whole look of it is just think more electrical activity if you see a bigger spike. So I'll use purple for this one. This is called the Qrs complex. So the Qrs complex, and what that is, what you're seeing, is the ventricles are depolarizing. So that's when the signal is passing down and up the ventricle walls. So Qrs complex is ventricular depolarization, and then the last bump is the repolarizing of those ventricles. We call that the T wave. This is ventricles repolarizing. So regaining their negative resting state. The atria also repolarize, but they're repolarizing while the ventricles are depolarizing, and so it's covered up or hidden. Then a couple of interesting things to put on here about disorders. There's something called WPW, or Wolff-Parkinson's-White disorder, so named after the three guys that work together. And what this is when cells in the atria are autorhythmic rather than obeying the SA node. So what can happen is that you get these aberrant pathways, sort of like the atria, or just the signal is just hanging out in the atria, never going down to the ventricles. It can cause tachycardia. And what they do usually is they'll take an ablation catheter and literally burn to death those cells that are being autorhythmic, kill them off so that they are no longer blocking the signal from going down to the ventricles like it should. So causes atrial fibrillation. And remember, fibrillating is when the heart is, a part of the heart is trying to beat so fast that it's not pumping. It is an ineffective pump if it's fibrillating. It's just like wiggling, almost like jello. Okay, then the other, a similar problem is an ectopic focus, or if you plural, ectopic foci. And this is a similar kind of thing, but usually not dangerous. It's when you have a few renegade cells, myocardial cells, try to set their own rhythm. And again, this is going to disturb the normal depolarization and contraction of the heart. And you can feel this if you've ever listened to your heart and you feel it go bump, 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 bump. And you can feel that every once in a while you skip a beat or you have a few extra beats. It's usually because renegade cells are trying to set their own rhythm. A lot of people have this and it's not dangerous, but the question is, when it does become dangerous, which WPW is a disorder in which it is dangerous. So it just depends. I guess it can be a spectrum of purely harmless to life-threatening. But if you have some of these cells, you might notice that they are more active in their autorhythmicity if you're under stress, you're fatigued, if you've had too much caffeine, which stimulates those nerve endings and makes the renegade cells more active, maybe if you are dehydrated. So all of those environmental things can cause those ectopic foci to be more active.